Pero hello, Deepak Rokre. ഇതിനെ ഞാൻ പറയാം, കേൾക്കുന്നുണ്ട് നമുക്ക്. ഹലോ ഹലോ ഇല്ലേ? കേട്ടാ വേറെ ആരെങ്കിലും കാണുന്നുണ്ടോ ഇതിന്?
Hello.
സാറേ.
Yes, yes.
സാറേ സ്ക്രീൻ ഷെയർ ചെയ്യാൻ പറ്റില്ലേ? നോക്കൂ.
നോക്കാം. സ്ക്രീൻ ഷെയർ ചെയ്യാനാണ് നോക്കുന്നത്.
സാറേ എന്താ സാറ് കോ ഹോസ്റ്റ് ആണല്ലോ, അപ്പൊ ചെയ്യാൻ പറ്റേണ്ടതാണല്ലോ.
ഞാൻ അതാണ് നോക്കുന്നത്. ഒരു മിനിറ്റ്. ഇസാനൊന്ന് വിളിക്കാം. ഇസാനൊന്ന് വിളിക്കാം. ഹലോ 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 കേൾക്കാവോ? ഹലോ 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 ഫസൽ, ഹലോ.
ആ സാർ, കേൾക്കാം കേൾക്കാം.
ആ കേൾക്കാം. ഓക്കെ 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 ഓക്കെ, താങ്ക് യു. കേൾക്കും കാണുകയൊക്കെ ചെയ്യാലോ. സ്ക്രീൻ
എല്ലാം
ഷെയർ
ഓക്കെയാണ്,
സ്ക്രീൻ
എല്ലാം
ഷെയർ
ഓക്കെയാണ്.
ചെയ്ത് കാണാലോ അല്ലേ?
ആ സാർ ഇനി സ്ക്രീന് വലുതാക്കിയാൽ മതി. അത് തുടങ്ങുമ്പോൾ
യെസ് 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 യെസ്.
യെസ്. ദീപക് ഡോക്ടറെ.
യെസ്, ഞാൻ ഇവിടെ ഉണ്ട്.
ആ സ്റ്റാർട്ട് ചെയ്യല്ലേ?
സ്റ്റാർട്ട് ചെയ്യണം. ഓക്കെ, എല്ലാവരും എത്തിയോ? എല്ലാവരും എത്തിയിട്ടുണ്ടാവും അല്ലേ? We'll start in a couple of minutes.
Yeah, absolutely fine.
Okay, sir.
Hello,
Sorry to
hello,
meet you.
Dr. Deepak.
Hi, sir.
Hi.
So, very good evening to all. Sorry to keep you all waiting. So today, as you all know, February 4th is celebrated as is observed as the World Cancer Day, and Idea Kunnamkulam, as a part of its, we are observing the World Cancer Day today by conducting its our second webinar, and we are proud and privileged to have Dr. Auwsaf Ahsan sir as our speaker today. Thank you, sir, for being a speaker today. Thank you. So the theme for this year is Close the Care Gap. So as you all know, sir will be taking the topic for today. So a brief introduction of our speaker today. Dr. Ahsan sir, he was the oral physician. He is the oral physician at IFRA International Hospital and Research Center. And he's the managing editor of other books, chairman, photonic imaging solution, and he was the former head of faculty and the professor of KMCT Dental College. So without any delay, I would hand over to Ahsan sir for the webinar today. Thank you, sir, once again.
Thank you, Dr. Deepak. What to say? I really don't know. I mean, I should thank Idea Kunnamkulam first for inviting me and showed the courage to listen to 1 hour lecture on or 45 minutes lecture on cancer, which none of us are unfamiliar of, either by learning during our BDS days or by seeing cases on later date, like in our clinics, or at times known people around us might as well have gone through this ordeal. Having said this, I really do not know personally. I mean, when we observe a day, it like we have every day is observed as another, this day and that day and whatnot. So it should not, cancer should not go in that manner, like yet another day. So it should be with us because it is around us all the time. You watch a nice movie, then you have cancer in it. You read a wonderful book, there is cancer in it. You see many patients, one among them will definitely have something to tell you about cancer. So that is to begin with, and I should thank Dr. Faisal also, because it gives immense pleasure. ശരിക്കും സന്തോഷം ഉണ്ടാവും അങ്ങനെ UG ഡേയ്സിൽ നമ്മൾ ഒരുമിച്ചുണ്ടായിരുന്ന ആളുകൾ അവരെ ഇൻവൈറ്റ് ചെയ്യുമ്പോൾ അങ്ങനെയുള്ളൊരു സദസ്സിൽ പങ്കെടുക്കുക എന്ന് പറയുന്നത് ശരിക്കും ഒരു സന്തോഷം തരുന്ന കാര്യം കൂടിയാണ്. അതും കൂടെ എടുത്തു പറയാണ് ഞാൻ. ആദ്യം ഞാൻ നേരത്തെ ഇവിടെ ഇല്ലാത്ത ആളുകൾക്ക് വേണ്ടി പറയാണ് ഐഡിയ കുന്നംകുളത്തിന് ബ്രാഞ്ചിന് ഒരു പ്രത്യേകം എൻ്റെ മനസ്സിൻ്റെ ആഴങ്ങളിൽ നന്ദി പറയാണ് നിങ്ങളോടൊപ്പം കൂടാൻ കഴിഞ്ഞില്ല ഈ സായാഹ്നത്തിൽ ഈ വൈകുന്നേരം. ഇനി ചില കാര്യങ്ങൾ പറഞ്ഞു തുടങ്ങുകയാണെങ്കിൽ, ഈ പാൻഡമിക്കോട് കൂടെ വന്ന ഒരു കമ്പനിയാണല്ലോ സൂം. ബില്യൺസിന്റെ ടേൺ ഓവർ ഉള്ള ഒരു കമ്പനിയാണ് സൂം. പക്ഷെ ഇഫ് ഐ ടെൽ യു ഫ്രം ദ ഹാർട്ട് ഓഫ് ദ ഹാർട്ട് എന്നൊക്കെ നമ്മൾ പറയും അല്ലേ, അങ്ങനെ പറയുകയാണെങ്കിൽ ശരിക്കും എൻ്റർ ദ ഡ്രാഗൺ എന്ന് പറഞ്ഞൊരു പഴയ പടമുണ്ട്, പലർക്കും അറിയാം. ക്ലാസിക്കൽ ഈ 36 ചേംബർ ഓഫ് ഷാലിനൊക്കെ പോലെ അതിൻ്റെ ഒക്കെ മുമ്പ് ഇറങ്ങിയ ബ്രൂസ്ലി ഒക്കെ ഉണ്ടായിരുന്ന, ജിം കെല്ലി ഒക്കെ ഉണ്ടായിരുന്ന എൻ്റർ ദ ഡ്രാഗൺ എന്ന് പറഞ്ഞൊരു പടം ഉണ്ടായി. ഞങ്ങളൊക്കെ +1 +2 ഒക്കെ ചെയ്യുമ്പോൾ 80s ഉണ്ടായിരുന്ന ഒരു പടമാണ്. ഈ എൻ്റർ ദ ഡ്രാഗണിൽ അവസാനം ഒരു കണ്ണാടിക്കൂട്ടിൽ കയറുന്നുണ്ട്. നിങ്ങൾ പലരും കണ്ടിട്ടുണ്ടാവും ആ സിനിമ. കണ്ടിട്ടില്ലെങ്കിൽ എപ്പോഴെങ്കിലും വെറുതെ ഇരിക്കുമ്പോൾ ഒക്കെ കാണാൻ പറ്റിയ ഒരു സിനിമയാണ്. ഇപ്പൊ അതിന് വലിയൊരു ആ തരത്തിലൊരു പ്രസക്തി ഇല്ല. എന്നിരുന്നാലും ബ്രൂസ്ലി ഒരു ഹീറോ തന്നെയായിരുന്നു ഒരുപാട് കാലത്ത്. അപ്പോൾ ബ്രൂസ്ലി ഒരു കണ്ണാടിക്കൂട്ടിലാണ് കയറുന്നത്. അപ്പോ ഈ എവിടെയാണ് ആളിരിക്കുന്നത്, ബ്രൂസ്ലിയെ ഫേസ് ചെയ്യുന്ന ആള് എവിടെയാണെന്നുള്ളത് അറിയാൻ പറ്റില്ല. ഒരുപാട് ഇമേജസ് ആണ്. അതുപോലെയാണ് ശരിക്കും ഈ വെബിനാറുകളിൽ വന്നിരിക്കുമ്പോൾ ചിലപ്പോൾ ഉണ്ടാകുന്ന ഒരു ഫീലിംഗ്. അവിടെ ശത്രു സംഹാരമില്ല, പക്ഷെ സുഹൃത്തുക്കൾ തന്നെയാണ്. ബട്ട് പല ആളുകളും പല ഭാഗത്ത് ഇരിക്കുന്നുണ്ടാവും. എങ്ങനെയാ ഇരിക്കുന്നത്, ഏത് രീതിയിലാണ്? കാരണം വീട്ടിൽ മക്കളൊക്കെ ക്ലാസ് അറ്റൻഡ് ചെയ്യണത് കണ്ടിട്ടുണ്ട്. സ്പ്ലിറ്റ് സ്ക്രീനിൽ ഒന്നിൽ അവർ സീരീസ് കാണുന്നുണ്ടാവും, മറുഭാഗത്ത് അവർ ഇങ്ങനെ ക്ലാസ്സും അറ്റൻഡ് ചെയ്യുന്നുണ്ടാവും. അപ്പോൾ ഇങ്ങനെയുള്ള ഒരു യുഗത്തിലേക്ക് നമ്മൾ കടന്നു വന്നല്ലോ. നമ്മൾ ന്യൂ era, we usually call it as paradigm shift, that you don't see anybody and you speak to the screen and you look to the screen, and it has lost meaning. I mean, if you are looking at screen hours, how many screen hours you have passed on a particular day എന്ന് വെച്ച് നോക്കുമ്പോൾ, കാരണം സ്ക്രീനിൽ ഒരു രീതിയിലുള്ള സ്ക്രീൻ അല്ലല്ലോ നമ്മൾ കാണുന്നത്. വി സി ടെലിഫോൺ and then we see computer screen like this, and you see TV on another after a while. അങ്ങനെ പോകുന്ന ഒരു കാലത്ത് ഇതല്ലാതെ നിവൃത്തി ഇല്ലാത്തത് കൊണ്ടും ഇത് കുറെ ആളുകളെ കണക്ട് ചെയ്യുന്നത് കൊണ്ടും ഇതിനോട് പൊരുത്തപ്പെടാൻ ശ്രമിക്കുകയാണ് നല്ലത് എന്നാണ് മനസ്സിലാകുന്നത്. സിനിമ നല്ലതാണെങ്കിലും അല്ലെങ്കിലും ബ്രോഡാഡി ഒക്കെ കഴിഞ്ഞ കാലമാണല്ലോ. അപ്പോൾ നമ്മൾ ഡാഡി എന്ത് കേട്ടാലും അതിന് കൂടെ നിൽക്കണം എന്ന് പറയുന്ന പോലെ, പ്രായം 56 ആയാലും റിട്ടയർ ചെയ്താലും ഐ ഷുഡ് സ്റ്റാൻഡ് വിത്ത് ദ പീപ്പിൾ. അപ്പോൾ ഇതങ്ങ് ശീലമാവണം, വെബിനാറുകൾ ശീലമാവണം എന്നാണ് പറയുക. എന്ത് തന്നെ ആയാലും അങ്ങോട്ട് ശരിയാവുന്നില്ല എന്ന് പറയാറില്ലേ പ്രായമായ ആൾക്കാർ? അതുപോലെ ഒരു ഫീല് എനിവേ ഇറ്റ് ഗിവ്സ് യു. സോ കമ്മിങ് ടു ദ ടോപ്പിക് നൗ, we call it close the care gap എന്നാണ്. വേൾഡ് ക്യാൻസർ ഡേക്ക് ഒരു തീമായിട്ട് വെച്ചിട്ടുള്ളത്, 3 വർഷത്തേക്കുള്ള തീമായിട്ടാണ് ഈ ക്ലോസ് ദ കെയർ ഗ്യാപ്പ് എന്നുള്ളത് വെച്ചിട്ടുള്ളത്. അപ്പൊ നമുക്ക് പല പെർസ്പെക്റ്റീവ്സിലും നമുക്ക് വേണമെങ്കിൽ ഇതിനെ കാണാൻ പറ്റും. അതായത് ക്യാൻസറിനെ കുറിച്ചുള്ള ഡിസ്കഷൻ. ഇപ്പൊ ഓറൽ മെഡിസിന്റെ ഒരു ഫാക്കൽറ്റി ആയി കുറെ കാലം വർക്ക് ചെയ്ത ഒരാള് ക്യാൻസറിന്റെ നൂതനമായ കാര്യങ്ങളെ കുറിച്ച് പറയണമെന്നോ അങ്ങനെയൊക്കെ വേണമെങ്കിൽ വെക്കാൻ പറ്റും. പക്ഷെ ഇത് എനിക്ക് തോന്നുന്നില്ല, എനിക്ക് അങ്ങനെ തോന്നിയില്ല ഈ ഒരു ഗ്യാതറിങ് അങ്ങനെയുള്ളതായിരിക്കും എന്ന് തോന്നിയില്ല. അപ്പൊ അതുകൊണ്ട് തന്നെ വാട്ട് ഐ തോട്ട് വാസ്, അങ്ങനെ നോക്കുന്നതിലും വി എന്നുള്ള ഒരു കൺസെപ്റ്റിൽ, അതായത് നമ്മൾ കെയർ കൊടുക്കുക വേറുള്ളവർക്ക് എന്നുള്ള, വി ദ കെയർ ഗിവർ ഓർ ഹെൽത്ത് കെയർ ഗിവർ എന്നുള്ള ഒരു കോൺസെപ്റ്റിൽ നിന്ന് മാറിയിട്ട് കളക്റ്റീവായിട്ട് വി ഷുഡ് അഡ്രസ് ദ പ്രോബ്ലം. അതായത് നമ്മൾ കളക്റ്റീവായിട്ട് ക്യാൻസർ ഈസ് എമംഗ് അസ് എന്നുള്ള രീതിയിൽ നമ്മുടെ ചുറ്റിലും എവിടെയൊക്കെയോ ഉള്ള ഒരു സംഭവമാണ് അല്ലെങ്കിൽ ഒരു കാര്യമാണ് ക്യാൻസർ എന്ന് നമ്മൾ മനസ്സിലാക്കുമ്പോഴേ അതിനൊരു ഈ ഒരു ഡിസ്കഷൻ ഒരു ജീവൻ ഉണ്ടാവുകയുള്ളൂ എന്നെനിക്ക് പേഴ്സണലി തോന്നി. അപ്പൊ അതുകൊണ്ട് എന്താണ്, ഏതൊക്കെ ടൈപ്പ് ക്യാൻസർ ആണ്, ഓറൽ ക്യാൻസർ എങ്ങനെയാണ്, എന്താണെന്നൊക്കെ പറയുന്നതിനേക്കാൾ ഉപരിയായിട്ട് വാട്ട് ഐ ഫെൽറ്റ് വാസ് വി ഷുഡ് ഫസ്റ്റ് ഇന്റേണലൈസ് ദ ഇഷ്യൂ. അതർവൈസ് എന്താ ചെയ്യുക, ക്യാൻസർ എന്നുള്ള പദം ഇങ്ങനെയാണ് വന്നിട്ടുള്ളത്. ക്യാൻസർ ലോകത്ത് ഇത്ര പേരെ ബാധിക്കുന്നുണ്ട്, അത്രയും ആളുകൾ ഇന്ത്യയിൽ ഓറൽ ക്യാൻസർ കൊണ്ട് മരിക്കും. ഈ സ്റ്റാറ്റിസ്റ്റിക്സ് മുഴുവൻ ഇപ്പോൾ നിങ്ങൾക്ക് ഫിംഗർ ടിപ്സിൽ കിട്ടും, ഗൂഗിളിൽ കിട്ടും. എന്ന് മാത്രമല്ല, ഇന്ന് നിങ്ങൾ അത് സെർച്ച് ചെയ്താൽ നാളെ ഗൂഗിൾ നിങ്ങളോട് പറയും എത്ര പേര് ക്യാൻസർ വന്ന് മരിക്കുന്നുണ്ട്. കാരണം നിങ്ങളുടെ ആ ലൈനിൽ നിങ്ങൾ പോയി കഴിഞ്ഞു. ഇനി ഗൂഗിൾ നിങ്ങളോട് സ്ഥിരമായി പറഞ്ഞുകൊണ്ടിരിക്കും അതാണല്ലോ ഗൂഗിളിന്റെ രീതി. അതിൽ വേറെ ഒരു പുസ്തകവും ഉണ്ട്, ഗൂഗിളൈസേഷൻ ഓഫ് എവറിത്തിങ് എന്ന് പറഞ്ഞിട്ട്. നിങ്ങൾക്ക് ആർക്കെങ്കിലും അതിൽ താല്പര്യം ഉണ്ടെങ്കിൽ അത് വായിക്കാം. കാരണം ചില ഡോക്യുമെന്ററികളൊക്കെ നിങ്ങൾ കണ്ടിട്ടുണ്ടാവാം ഈ അടുത്ത കാലത്ത്. സോഷ്യൽ ഡയലമ ഒക്കെ ഒരു ഇതെല്ലാവരും കണ്ടിട്ടുണ്ടാവും, മിനിമലിസം ഒക്കെ പലരും കണ്ടിട്ടുണ്ടാവും. അങ്ങനത്തെ ഒരു സമയത്ത് നമ്മൾ ഗൂഗിള് നമ്മളെ ഗൈഡ് ചെയ്തുകൊണ്ടിരിക്കുന്ന സമയത്ത് സ്റ്റാറ്റിസ്റ്റിക്സിന്റെ വില ഇത്തരം ലെക്ചറുകളിൽ കുറഞ്ഞു പോകുന്നു, കുറയണം എന്നാണ് വിശ്വസിക്കുന്നത്. കാരണം അല്ലെങ്കിൽ ഈ സ്റ്റാറ്റിസ്റ്റിക്സ് നിങ്ങൾക്ക് അല്ലെങ്കിലും അവൈലബിൾ ആണ് പുറത്ത്, അതുകൊണ്ടാണ് ഞാൻ പറയുന്നത്. അപ്പോൾ ആ ഒരു നിലയിൽ അത്തരം സ്റ്റാറ്റിസ്റ്റിക്സുകൾ വെച്ചുകൊണ്ട് നമ്മളാണ് കെയർ ഗിവർ എന്ന് സങ്കല്പിക്കുന്നതിന് ഉപരിയായി നമ്മൾ എന്ത് ചെയ്യുക എന്ന് പറഞ്ഞാൽ, നമ്മൾ പണ്ട് 1980s ആൽവിൻ ടോഫ്ലർ എന്ന് പറഞ്ഞിട്ട് ഒരാൾ തേർഡ് വേവ് എന്ന് പറഞ്ഞൊരു പുസ്തകം എഴുതിയിരുന്നു. 1980 41 വർഷം മുമ്പാണ്. അദ്ദേഹം അതിൽ പറയുന്നത് പ്രൊഡ്യൂസർ എന്ന് പറയുന്ന ഒരവസ്ഥയും കൺസ്യൂമർ എന്ന് പറയുന്ന മറ്റൊരവസ്ഥയും, അതായത് രണ്ടാളുകളാണല്ലോ, ഒരു സാധനം പ്രൊഡ്യൂസ് ചെയ്യും, മറ്റേ ആൾ കൺസ്യൂം ചെയ്യും. ഈ രണ്ടവസ്ഥയും നമുക്ക് ഇല്ലാതെ പ്രൊസ്യൂമർ എന്നുള്ള ഒരവസ്ഥ വരും. പ്രൊസ്യൂമർ എന്നുള്ള അവസ്ഥ വരും. ഈ പ്രൊസ്യൂമർ എന്നുള്ള അവസ്ഥ പോലെ ഇതിനെ നമ്മൾ പരിഗണിച്ചാൽ നമ്മൾ കെയർ ഗിവർ എന്നുള്ളതിൽ നിന്ന് മാറി നമ്മൾ ഇതിനെ എങ്ങനെ കലക്റ്റീവായി നേരിടും എന്നുള്ള ഒരു കാര്യത്തിലോട്ട് നമ്മൾ കടന്നെങ്കിൽ മാത്രമേ നമുക്ക് ഈ ക്യാൻസറിനെ നേരിടുന്നതിൽ നമുക്ക് ഒരു സ്ട്രാറ്റജി, നല്ലൊരു സ്ട്രാറ്റജി ഉണ്ടാക്കാൻ പറ്റുകയുള്ളൂ എന്നുള്ളതാണ് നമ്മൾ ഇതിൽ മനസ്സിലാക്കാനുള്ളത്. അതായത് വി ഡിസേർവ് ആക്സസ് ടു ആക്യുറേറ്റ് ഇൻഫർമേഷൻ ഓൺ ക്യാൻസർ എന്ന് മാത്രമല്ല, അതിൻ്റെ പ്രിവെൻഷൻ, ഡയഗ്നോസിസ്, ട്രീറ്റ്മെന്റ്, സപ്പോർട്ട്. പ്രിവെൻഷൻ എന്ന് പറയുമ്പോൾ ഇതിലുള്ള ഇൻഫർമേഷൻ നമ്മൾ ആദ്യം കൊടുക്കുക, ഡയഗ്നോസിസ്, ഏർലി ഡയഗ്നോസിസ്, ഞാൻ അതിലേക്ക് വരാം. ട്രീറ്റ്മെന്റ് പാർട്ട് നമ്മളെ സംബന്ധിച്ചിടത്തോളം നമ്മൾ ചെയ്യുന്നതല്ല, എന്നിരുന്നാലും ട്രീറ്റ്മെന്റിന് വേണ്ട ഗൈഡൻസ്, പിന്നെ അത് കൂടാതെ പാലിയേറ്റീവ്, ഇന്ന് ഡോക്ടർ സുരേഷിന്റെ ഒക്കെ നേതൃത്വത്തിൽ വൻ സംഭവമായിട്ട് കേരളം മാറിയിട്ടുള്ള ഒരു ഏരിയയാണ് പാലിയേറ്റീവ് തെറപ്പി എന്ന് പറയുന്നത്. അപ്പോൾ പാലിയേറ്റീവ് തെറപ്പിയിൽ ടെർമിനലിയിലായ പേഷ്യൻസിനെയാണ് നോക്കുന്നത്. അതിൽ ഒന്നാണല്ലോ ക്യാൻസർ. അപ്പൊ അവിടെ ആ ഒരു സപ്പോർട്ട് നമുക്ക് കൊടുക്കാൻ പറ്റുക എന്നുള്ളത്, ഇത്രയും കാര്യങ്ങൾ ആണ് അതിലുള്ള. അപ്പൊ ഞാൻ ചുരുക്കി പറഞ്ഞാൽ ഇത്രയും പറഞ്ഞു വന്നത് അതാണ്. അതായത് നമ്മൾ ഒരുമിച്ച് നേരിടുക ഈ ഒരു പ്രശ്നത്തെ. അപ്പോൾ ഇന്നലെ കണ്ട ഒരു കേസ്, മിനിയാന്ന് കണ്ട ഒരു കേസ്, മിനിയാന്നാണോ ഇന്നിപ്പോ ഫ്രൈഡേ, ലാസ്റ്റ് സാറ്റർഡേ കണ്ട ഒരു കേസ്, ഇന്ന് കണ്ട കേസ് അവർക്ക് ക്യാൻസർ ആണെന്നുള്ള ധാരണയിൽ വന്നതായിരുന്നു. ക്യാൻസറോഫോബിക് ആയിരുന്നു, ലൈക്കൻ പ്ലാനറ്റ്സ് മാത്രമായിരുന്നു. യെസ് ദീപക്, എനിത്തിങ്?
There is one doctor from Tamil Nadu. Actually, she was saying she was not able to understand that.
Oh, absolutely no problem. Absolutely no problem. Hello, may I know his name, please? His or her name, please? I'm sorry.
Her name is Dr. Deepa.
Oh, Dr. Deepak. Okay, you are also Dr. Deepak, right? Deepa. Okay. All right. I'm extremely sorry to keep you guessing what kind of a language I am talking in. I'm really sorry, but let me tell you that cancer has got no language. Yesterday, I had a patient. Today afternoon, while I was seeing a patient, she said, I have a problem. Look, she is coming from Wayanad. It's a far off place. And I checked her, it was lichen planus. And then she suddenly, you could see tears, because it was a referred case. So she said, in Malayalam we say Madhavinodu, meaning I was praying to my mother. So that was a Catholic prayer that and she was crying. She thought that she is cancerous. There was a cancerous growth in her mouth, she thought. So okay, so this is what I want to say. I want to say that we are collectively facing it. So prevention, diagnosis, treatment, and support, all these areas we deserve more, much more, right? And now let us think about our barriers. That is, of course, yes, income, because there is a gross mismatch in our treatment facilities and our income, because we usually calculate in GDP and say that, okay, we are improving. But Kerala had a wonderful healthcare system, public healthcare system, which is slowly and steadily deteriorating, because the public health centers, government dispensaries, district hospitals, and it is one-on-one, and it goes on and reaches to medical colleges. So now it is slowly deteriorating. Education in the sense that, okay, coming to see the micro level, you see education on cancer itself. How many people are educated in cancer? And this is one of the efforts actually. And how many people we can reach up to? That is a question. That is another barrier. Geographic location. Kerala, even though is celebrated as a big city, still we have extremely difficult places, especially towards the east. West, we have a sea, big sea, and east we have mountainous region, and we have 44 rivers cutting across. A beautiful land, God's own country. But the issue is people from there to reach towards the coastal areas. Mostly coastal areas are denser, thickly populated, and more health facilities are over there. So cancerous patients will find it almost always difficult. Geographic location is another one. Discrimination on the basis of ethnicity, caste, gender, sexual orientation, age, and lifestyle. So many, you all know all this, but again, I am just reminding you of all this. So these most disadvantaged groups are more likely to have increased exposure to these vices. So they are more exposed to these issues, and they find it difficult to, first of all, get it diagnosed early. Then, like I told you, a patient who had to travel around 60 to 70 kilometers from Wayanad, and the kilometers is one thing, and the travel is another thing. From Wayanad is a hilly area, so from there to travel, come down, go back, it takes one whole day for her to come down and know that she has got no cancer. So this is the situation, and I'll tell you, I mean, the welfare states, like I remember a story written by a famous poet in Kerala. We call him Sachimash, Sachidanandan. He said when he was in Finland, midnight, 12 o'clock, he was walking after a meeting and a small party, cocktail, and he was walking down the street. It was around 12, not winter or peak winter or peak summer, whatever it is, it will be cold. And he saw a beautiful young lady walking with a white cane on the street. So he helped her. I mean, he looked at her, and another person came in. He gave her hand and made her cross the road, and he left. He said, I don't think we can see this in our place. So what I mean to say is, we have to inculcate in us, how do we perceive, how do we see the disadvantaged people? It is extremely difficult. We all think that, okay, I think I know. Yeah, I know who is disadvantaged. But someone else has to tell you, look, this is not the right way. Then we realized, oh, yeah, because we were never in that shoes, in their shoes. So it is extremely difficult to understand how a disadvantaged person is, what sufferings they have. So they are most disadvantaged people are exposed to tobacco, unhealthy diet, and environmental hazards as well. So this is what are the barriers which we face. Now let us see how do we see. Before I continue, I should tell you that mostly this material is taken from close the care gap, close the care gap team, when they discuss on their website. I have been reading that for 2 days, thanks to you people for organizing this, because I got to know many new things from there for this presentation. Right. So this is one thing which you have to understand. Now coming to smoking, alcohol, smoking and pan, alcohol, physical activity, ultraviolet radiation, and workplace hazards. I just want to focus on a couple of minutes on smoking and pan chewing. In 1999, we had a ban in Kerala that you can't smoke in public places. Personally, I'm not a smoker, but I have smoked cigarettes, cigars, and so on. But I'm not a smoker, but most of my friends do smoke. I mean, they used to smoke before, because I was in Karnataka for 15 to 16 years, doing my UG and PG, and then as a faculty. So there, this ban was not in place. They used to smoke. Smoking, when it was banned in public places in Kerala in 1999, smoking came inside the house, right? So smoke, it was easier for women to have men smoking outside. And you might ask me, why are you showing a kind of gender bias? Women also smoke. Yeah, I know. In fact, in the beginning of the feminist movement in the United States, they started by smoking and driving. I mean, later feminism grew into a different branch in itself, and it is addressing so many problems faced on the basis of gender. That is altogether a different topic. And smoking was a problem here, and it was banned, but it did not go. But we had many migrant laborers here, Aditi Thorilaligal. So they came from, first they were from Tamil Nadu, and later they were from Bihar, West Bengal, Odisha, Assam, and on. So these people had their own cultural issues, right? Issues like we used to smoke, we used to cultivate a lot of arecanut and so on, but they as well. And in fact, smoking and pan is not such a big issue. Now we are facing many other issues. That is again an altogether different topic when we discuss cancer. And alcohol, yes, Kunnamkulam branch, right? I think Ponnani, I think Fazal knows. Ponnani is a leading consumer of alcohol when we discuss about alcohol, right? When we see every year, this alcohol is a very, accepted co-carcinogen. That way, that also is another issue. Physical activity, I used to ask my students mostly when they come for their third year postings during my teaching days, how many, as you all know, there is a very high gender presentation in dental college enrollments. That is more than 85%, at times more than 80% are females among the students. So these students I used to ask many of them, most of them, when they come for their third year postings, first introductory discussion, I used to ask, how many of you swim? Very, very rare. They don't swim usually. Our 44 rivers are not enough. And thousands, hundreds and thousands of ponds are not enough to swim, and swimming pools are not enough. If somebody says, yes, sir, I swim, then obviously that girl must be from GCC countries. Mostly. Then I guess, okay, are you from GCC? Any of those GCC countries, Dubai or Bahrain or Qatar or Kuwait? Or then they say, yes, sir. How did you guess? I said, yeah, I'm sure, because in our place it is extremely rare. So physical activity, one of the physical activities which we used to have, was swimming. That has reduced, but we need to get back such things. I'm not saying that we should all go and take a splash in rivers which are highly polluted. But can you hear me? Is it okay? Hello? Am I audible, Deepak? Dr. Deepak? Dr. Fazal? Okay. So this is what I wanted to say. I'm not going into the details of ultraviolet radiation, where we are suffering from vitamin D deficiency all over. Most of us will go for injections at times. And I draw your attention, if you are keen to discuss this, to a document which was produced by the government, state government, Kerala, Department of Health and Family Welfare, Government of Kerala. They produced in 2019 a document as standard treatment guidelines for common cancers. This is version 1. They have said around 5 or 6 points where they will revise this. Okay. If you are interested, it is downloadable. All right. You can please get my phone number if you need any help to download. I mean, it is easily available. You give this Google search, you get it. But what I want to tell you is, here in this document, number of doctors are mentioned. For preparing this document, they have depended upon many, taken help from many, around 2000 odd, more than 2010, 2016, somewhere around. And I seriously checked. There was only one, I think, Dr. Moni Kuriakos, who is a very famous maxillofacial oncosurgeon. Is the only one, a good friend of mine too, only one who was mentioned in that. Mind you, we have tens of hundreds of oral cancer cases here, and we do report, but not a single one from our side. I don't blame the document of the government, and I don't want to blame us too, but let us consider this as an eye-opener. Like, we need to contribute, we need to see this, and you please go through the document, just flip through the document, because it is 300 odd pages. I don't think, and in a dry language, mostly it will be so. It won't be like a thriller. So let us be proactive, as people, motivational speakers say, and try to understand the situation of oral cancer a bit more deeply, so that we can discuss with people, educate them, and also the coming generation. I'm coming to it. Before I move on, I'll discuss three, four or five cases with you. That usually what we discuss is what tobacco does. But now we have another issue here. Not only tobacco is harming us, there are other reasons as well, where we all can play a very, very important Very important role. That's what I want to stress upon. Case number 1, a 28-year-old female. Since 2 months, she has these problems. Single, irregular, you can see ulceroproliferative lesion with rolled out edge. It is 2 into 3 centimeters on left lateral border of the tongue, ulcers on the lateral border of the tongue for more than 3 weeks. Antennas should be up of any dentist. Please do not delay. See the best place where you can refer them. Let an expert check and then move forward. When checked, there was induration on palpation and at a closer look, there was a sharp cusp of lower molar. This lower molar was hurting her maybe more than 2 months. So here, what we see is a sharp tooth, which is causing an issue. Not tobacco, not pan chewing, not any of that sort. Usually, it is left as a harmless kind of ulcer, and we give all kinds of treatments. But I'm telling you, she is otherwise normal, not diabetic. That is what we should keep in mind. If she is diabetic, fine, delayed healing, but there is no diabetes. So there is an ulcer. She is young, 28. Tongue is highly vascular. It should have healed much earlier, but that did not happen here. So this is what, and it histopathologically, as you can see, it was declared as moderately differentiated squamous cell carcinoma. Now, non-healing ulcer, 70-year-old male. On, again, 2 months, there was an edentulous ridge extending to adjacent vestibule. It was because of the overextended flange of a denture. That is another area where we have to always look for. That is, if you see an ulcer, look for iatrogenic reasons and find out what it could be, right? So a non-healing ulcer, again, I haven't mentioned about systemic issues here, whatever it is, but you notice the location of the ulcer, shape of the ulcer, a denture user. We should never forget these issues. Don't get carried away by the habits and other issues. Of course, yes, if there is a habit, yes. Again, 37-year-old male, case number 3. 1 month old, they say, an ulcero-infiltrative lesion, not proliferative, diameter 1 centimeter, seen on left lateral border of the tongue, and there was lingually tilted lower third molar, left third molar. It also turned out to be moderately differentiated squamous cell carcinoma. Point stressed is, if there is an ulcer which does not heal in a patient who is otherwise normal, your antennas, our antennas should go up, right? And now other lesions, there are many, but I'll discuss 1 or 2 with you. White patch of the tongue, 2 years. White homogeneous plaque with striations, little bit of striations inside. It is not, you can call it as cracked mud there, appearance, right? Homogeneous it is. On the dorsum of the tongue, left side of the tongue, and size is 5 × 3 centimeters, solitary. You can see all this on the slide. I don't have to read it out. Again, it turned out to be malignancy. So if you see a white lesion, white patch, and it is unilateral, if it is bilateral and striated, think of lichen also. Otherwise, think of leukoplakia only. If it is homogeneous like that, okay, so go for leukoplakia, and then that there you have to refer again this case, because you can't delay it further. Earlier the better. One more case, a wound on the tongue for a month, again white plaque, right? It turned out to be carcinoma in situ. Okay, so I thought 5 cases I'll discuss with you. What do? We have a dentist patient ratio much better than what WHO demands. We all know. We all discuss this. We have 26 dental colleges, if I'm not wrong, in our state. We have 320 dental colleges all over India. India, with Mexico and Brazil, will make around 2/3 of all dental colleges in the world, right? So there are many countries where there are no dental colleges at all. Would you believe? Yes, there are countries which are not having dental colleges at all. But we have, a small state, have got 26 dental colleges, 25, 26, one is Mahi, if it is included that way. So, but still we are not able to. We tried 2 things. Once it was with the degree students, arts and commerce students in a college. They had an NSS program where we taught them in 4 to 5 hours how to look for a white lesion or how to look for an ulcer. And they had NSS program, that is National Service Scheme program. And in a panchayat, they selected wards and they screened patients. Whatever cases they brought, patients they brought, people they brought, we checked them again. And we could find only one, but one is very important. And in another occasion, what we did was, we tried to train the nursing students how to look for these lesions. Because you can't think of or ask people to check every day for lesions everywhere. It is difficult. A regular practitioner has got very little time with a patient. Patient will get irritated. They are not there for to get a screening check every day. So this nursing students, they too helped us. They could screen hundreds. And of course, you might ask, what if they make mistakes? True, they might make mistakes more than a trained person, but the trained person will back up. And if they miss, of course, yes, there is a miss. If they do not miss, if they make a mistake and bring them as a white lesion, then we are going to check and tell them it is not white lesion, it is linea alba, or it is photiasis granules, or whatever. All right. So as individuals, we can, as health professionals, we can influence individuals, train people, and go to policymakers, like every district has got. And in Kerala's document, they say collector is a person. Like IDA can do wonderful job here. Like, I'm not saying that screening the whole area or screening screening a ward at a time would be wonderful. You can train people, but you just have to be with them. 1 or 2 experts will be sufficient. That ward you can declare as no oral cancer ward, right? So, and the government, of course, many of you would be very influential people. You can always approach with a nice document that, of course, we can also contribute. Thereby, you will get into the policy program of the government, right? So this is another one. And also, while dealing with the patient, it is not that we are finding something wrong with them. No, preserve their dignity, talk to them in a very soft manner. Very difficult. We have like Kodiyeri Malabar Cancer Center, we have RCC in Trivandrum, we have MVR in Calicut, and also we have many private hospitals. These private hospitals are expensive for a common man, so you have to be gentle, preserve their dignity, and think about their well-being. Support them. We have to give a reference letter. We need to talk to the doctor concerned, because most of the things may not be discernible, understandable for the patient. We don't know, sir. That's what they say. Where to go, sir? What they will do. We are ready to pay, sometimes they say. But we don't understand what next. We can't take decisions for them. One patient once, while I was in Century, I heard, when I can see Fazal's face, so I remember Century Dental College days. A patient came, sat on the chair. My colleague was Dr. Vidyanath. He said, sir, one case is sitting. He was a BDS tutor that time. Now he is teaching oral pathology. So he told me, sir, there is a case. I think it is malignant. So, okay, professor went there, apron, nicely aproned, sat next to him and said, look, here we have a problem. Then patient told me, look, sir, I know what I have. I have 50,000 rupees with me. My daughter is going to get married. I know I have cancer. I don't need treatment. I just want to die a dignified death. I could not control myself, but somehow I managed to come off from there. So patients, their well-being, their decisions, their dignity, all depends on caregivers. We as caregivers sometimes slip. We think that, okay, we need to give them care. We are the people, we are moving the world, or we do nothing. We are one among them. And as caregivers, they need our attention. They need our care. And we need to keep this in mind all the time. And the power of our colleagues, we are not in, suppose we are working apart from this, we people have many other areas where we are working, right? Like, you're as IDA, you have dentist conglomeration, but you too will have many other areas where you are excelling, right? Some will play some games, some others are nice riders, some others are drive, they'll go for trips again, into many places as groups. So there too you have many peers, many friends. To them you can discuss at once a while. You can tell them what cancer is, how it is, what is the importance of screening, and so on and so forth. And ultimately we are coming to the last slides. We have, this crisis is not a crisis of one country. It is a global crisis. That is why from Geneva, they say today is a cancer day. It is a national crisis. We don't even have a proper registry, cancer registry. It is a crisis of an individual who is counting days. And of course, then people around him or her. So let us consider health is not a cost, but it is an investment, right? We have these gaps. Skill shortage we have, skills gap we have, but how to make up? As I told you, pick some people. Individually, I am prepared to come over. If we together train some people, no, it's a promise, yes. If nursing, any healthcare groups, if they want to get trained to see a lesion, white lesion, then they can refer that case to you, and you can again see and then refer them to one of these centers at the earliest, so that you can save life. And let us improve our skills also. How to diagnose a white lesion, how to feel for a lymph node, how to see an ulcer, whether it is indurated, rolled out, margins, right? How one ulcer differ from the other, and so on. So our parts, let us focus on governments, cities, companies, schools, wherever we can. Let us play our part. I once again thank you for all of you around. I can see many people listening. It is 8:21 now. We are almost more than, we have crossed 45 minutes. Thank you, one and all. Thank you, IDA Kunnamkulam branch. Thank you so much. If you have anything to talk to, please, no problem. I'm prepared. Hello, Deepak. Yes.
Yes, sir. Yes, sir.
Yes.
So we'll have a discussion session now. If anybody wants to ask any particular question to us, sir. Do not. Yes, sir. I don't think we have any question.
Fine, no problem.
Okay.
That our teachers say, if there are no questions, either people are fully understood or I am successful in confusing everybody. This is what lectures say.
Hello.
Yeah.
Good evening, sir.
Please. May I know you?
Thank you for the wonderful session.
Yeah. Thank you.
So my name is Dr. Auwsaf. Sir?
Yes, I can hear you. Please.
Yeah. So last sir talked about our role to the community.
Yes.
Of course, that was an brilliant idea about working with the social workers in eliminating or diagnosing it at the early stage. So how can we go ahead with that particular plan? Like with whom all to include in that particular team? And sir also is a part of Dentist and You, one of the sir's initiative, which also works along with for this particular as a pain and palliative care also, isn't it, sir?
Yeah, I can hear you. Yes.
Can you give more input regarding that?
Yeah. Actually, as you all know, it is always better to begin training from our own genre, species or genre, we say, dentists first. Let us know it better if possible, let us have such small programs, not big ones, small programs where we can identify white lesions early. One. Number two, health caregivers. We are all health caregivers. Other health caregivers like nursing, number one, because we are number one in the world in nursing. Number one in the world. If all the nurses in the world who are from Kerala is ready to stop working for 2 hours, more than 90% of the hospitals will become standstill. I'm quite sure. Even in Machu Picchu, I read recently, one person saw two ladies walking down, and then they talked, okay, they are Malus, but they are nurses from here. So nursing is another area. So this way, that is one thing. Second thing is, these terminally ill patients can't walk into a dental clinic. Most of the dental clinics are functioning on the first floor, as you know, because of recurring expenditure. We go for lesser rented spaces. So obviously, these patients can't walk up. On the other side, DCI says you can't go and treat them at home. Who will come and treat them, I do not know. Patients who are terminally ill, they lie down because of many diseases, accidents, trauma, and other problems. The state, district authorities, to form a small team, let us do that, right? If one person does, like this many dentists, one person does such a service one day, and if you can save one life by diagnosing it early, I personally feel that saving one life that's enough for a person to live a life. Okay, so this is possible, training of health workers and convincing the authorities that we are going for this. Obviously, authorities will help you, and pain and palliative that team has shown us it is one of the biggest pain and palliative effort in Asia, and they are training in Bangladesh, they are training in Thailand, they are training people everywhere. Sri Lanka, they are training everywhere. So it is possible. We can maybe associate with them and see the volunteers there. And it is not a time to elaborate upon this. What I am trying to tell you is 2 points. One, our own people, train our own people. Number two, whoever is prepared as a volunteer, let us train them. This is what we have experienced. Right.
Thank you, sir. So one more to add on, sir. So when we're talking about the process of...
was that Asaf, Dr. who asked?
Yes, sir.
No.
Yes, sir. Exactly,
okay,
sir.
Right.
So one more thing, sir. So a couple of cases which came to like our colleges were... so most of us are aware that the cancer causing due to smoking or alcohol. So apart from this non-tobacco causing cancers, as I earlier showed a few cases, I think in that aspect, more awareness should be built up among the dentists, because I personally had come across a couple of cases in which, as I said, they did not have any kind of habits, but still when they went for biopsy, and it turned out to be malignant.
Excellent. That's a very important thing, because sharp tooth and at times, unfortunately, iatrogenic reasons, they may not be aware. One denture given, it's given forever. So I absolutely agree with you. I absolutely agree with you. We have to create awareness on that.
So once again, thank you for the wonderful session, sir.
Thank you so much for listening to me.
Okay. Do any other doctors have any questions? Yeah, it's actually a very relevant topic, sir, because in the papers today, I just read that generally cancer, Kerala is among the first in the state by a huge margin. So it's time that we do something about it. Generally, for the past 2 years, probably I think Kerala is much ahead by a big number. So anyway, it's a
Thank you, Dr. Deepak. Thanks.
thank you,
Yes.
sir. So I would like to our CD chairman, Dr. Fazlur Rahman, to formally give a vote of thanks.
Yeah, thank you, Doctor. Good evening, all. It gives immense pleasure to deliver a vote of thanks. Firstly, Dr. Auwsaf Ahsan sir. Sir, ഈ കുറഞ്ഞ സമയം കൊണ്ട് it was a very short and explanatory talk. Thank you so much, sir. And so many of the participants were your students. So for them, it was a nostalgia. Thank you, sir. Thank you so much.
Thank you.
A special thanks to IDA Kunnamkulam team again. This is our second CDE. And thank you, IDA Kunnamkulam team, for the excellent support for this CDE program. And thank you so much for all the participants. So many are in a YouTube link and so many in Zoom. So thank you so much, all the doctors. Thank you all. Have a nice day. Thank you.
Thank you. Bye.
Bye-bye.
Thank you, sir, once again. Thank you.
Thank you.
On
Thank
behalf
you.
of
Bye.
IDA
Bye.
Kunnamkulam, thank you, sir.